Welcome, everybody. This is a brief faculty development at LIC 101. I am Dr. Sybil Cineas. I am the Assistant Director for the LIC, and I am joined by Dr. Megan Gary, the Director of the LIC, and Dr. Elizabeth Smith, who is the Director of the Primary Care Population Medicine Program. From now on, though, we're going to use first names because we're an informal group. I thought we would get started with some disclosures and introductions. We don't have any disclosures other than we love the LIC. Next slide. Today's learning objectives are that by the end of the session, you'll be able to identify ways to enhance continuity for students in the LIC, describe a method for evaluating clinical reasoning while working with students, review a template for evaluations. Evaluations are vital for our program, and also champion a positive learning environment for students. I think we'll start again with introductions. If you could tell us what specialty you're in, whether you're new to the LIC or not, and if you're not new, how many years you've been in the LIC, and also what you're hoping to get out of this session. Again, we're a small group, so we will keep things a little bit more conversational in style. I can start. Again, I'm Sybil Cineas. I've been involved with the LIC since our pilot year. And Elizabeth, can you remind me how many years this is now?
I think it's 9.
Wow. Okay.
Yeah.
So I'm not new to the LIC. I do have a student who works with me in the MedPeds clinic. My specialty is combined internal medicine and pediatrics. And my student works with me and one other preceptor in the MedPeds clinic. So he spends 2 half days doing both internal medicine and pediatrics. And what I'm hoping to get out of this session is to hear from you guys how things are going and to help you navigate maybe some challenges that you might be experiencing, and also to get ideas as to how we could be doing this better. And I'll hand it over to Megan.
Sybil, thank you so much. Megan Geary. I'm a general internist and work next door to Sybil in the Center for Primary Care. I was trying to do the math as well. I joined the LIC in the fall of 2019 and have a student in clinic with me. I am hoping to get out of this the same thing Sybil mentioned, and then really just looking to get to know preceptors that I haven't had the chance to meet in person. And I'll turn it over to Elizabeth.
My neighbor decided to power wash the house right now. So sorry. Elizabeth Smith, I'm the program director for the PCPM program and the assistant director for the Office of Medical Education. I've been involved in the LIC for many years, as I said, 9 years. So I know a lot, but I always learn something new at these sessions. So yeah, I'm happy to be here.
Thank you for joining us.
Yep.
Hi, I'm Rachel Taylor. I'm an OBGYN. I'm coming up on my first, end of my first year in the hospital system. So this is my first year doing the LIC program. And I'm, in general, looking to be involved in medical student education while I'm here. So this is me starting to dip my toes in that. For this session, I was just hoping to make sure I knew everything that I needed to do to give the student with me sort of like what she needed with this program.
What I'm going to talk about is some tips to promote continuity. Can you tell us how that's going for you in terms of continuity? Or is your student seeing patients repeatedly or following patients across the health system or attending a delivery after taking care of a patient for their prenatal care?
Yeah, those are all things that I'm thinking. So she's been with me for 3 or 4 sessions now with how it's worked out. I do prenatal care, so she'll have the opportunity to get continuity with prenatal patients, and I'm going to be working with her on maximizing having the patient come on the same half day that she'll be there. We identified one other patient who's sort of like an ovulation induction infertility patient who's going to have a lot of follow-up for that. So I think that that's something that's a little bit different. I haven't yet invited her to come inpatient for delivery and such. Obviously, that's not very predictable when that happens, but it was something I was thinking would be a nice and unique experience.
Fantastic. Yes, I think that would be a great next step also. We'll talk about some tips. Some of these may be applicable to your setting and some may not be as applicable. Again, feel free to comment and take away what you need from this. All right, so next slide. So continuity is the cornerstone of the LIC. There are many C's involved in teaching in the LIC, but continuity is the main guiding principle. That's continuity for patients, for preceptors, as well as the community. And this really adds a lot of value to the work that our students are doing. And it benefits both the students, it benefits the preceptor, as well as the patients. So preceptors can support and encourage continuity by first, having clear expectations for the students and holding the students accountable for following their patients across a variety of settings. This can be encouraged by notifying the students of like a patient admission if one of the patients that they're seeing is being admitted to the hospital, or if they have upcoming appointments at other subspecialties or other locations. And basically anytime they interact with the healthcare system. And then encouraging them to attend. So I'm not sure if you're aware, Rachel, that our students have what's called white space time. Do you know what that is? So it's basically they have like several half days during the week where it's unstructured, and during that time they can like attend an appointment with a patient. They can also work on other things. Sometimes they're working on personal things, or they're working on their thesis or other projects that they're working on. But it is time that they have set aside where we do expect them to do some of these continuity activities. And so another way that you can support continuity is to do some creative scheduling. So in my office, for example, my student has his own schedule. So we know in advance when a patient can be seen in the future, a patient that they've seen. So one of the things that we do is we ask him to walk the patient to the front desk and try to schedule the follow-up appointment at a time when we know that he's going to be in clinic. And this enhances the relationship as they are seeing the patient on multiple occasions. Other things that you do, Megan, to support this?
Yeah, I was just thinking, I don't know if CNE has Epic in the outpatient setting. I think Epic can be really helpful in like talking to my student about when a secure chat makes sense. Like if I'm letting someone know that I had a patient who went to the ER with a suspected ectopic pregnancy, and I did include the student in that secure chat because I thought it was important for them to know in real time. And then, for things that are less urgent, like a staff message, so that we're not interrupting each other during clinical care. So I think using the EHR to let students know what's happening in between visits, or following on that white space, having them come on a different day, or for part of a day if a patient's coming that day. Especially for OB patients, we really prioritize students, missing a clinic with myself or Sybil, to have that opportunity to see continuity in like the L&D setting.
Thank you for sharing that. Why don't we go to the next slide? So again, building connections between the patients and the students can really enhance that continuity. And a lot of the continuity does happen sometimes intuitively or with little effort, but it can also happen intentionally. So preceptors can make the efforts to connect students with patients who are enthusiastic to interact with students, patients who have complex medical needs that will be accessing the health system fairly frequently. So there's lots of more opportunities to actually follow a patient across the setting. And then also patients who might benefit from student advocacy due to complex social needs. And anyone who is likely to have multiple encounters with the healthcare system. So in your case, Rachel, your patients are coming back multiple times for their care. So that should be something that's a little bit perhaps easier to do. This is what's called an assent form that some of our students may be using in your settings. My student hasn't really been using it. Usually we connect patients with with students, by asking if it's okay, but this is another way of doing this. And basically, it's an agreement between the patient and the student, that they're agreeing to work with the student, and the things that the student may be helpful in working with them, such as explaining medical issues, checking in to see how they're doing between appointments. And then it also documents how they might like to be contacted, whether it's via phone call or through the EMR, or whether maybe they don't want to have any other contact except in the clinic setting. So I'm not sure if a lot of students are using this, but it is something that is available for students to use. Are you using these, Megan?
I don't think any of my students have really used it. I think it can be helpful at the beginning of the year to just have something to start a conversation.
Yeah, absolutely. All right. And then in terms of fostering communications, as Megan said, I think it's important to set clear expectations on how and when you're going to be communicating, whether it is through a text. My students have my cell phone number. Obviously, not to use any PHI in the text, but I'm saying, hey, please check your test results, or please check secure chat, or whether it's going to be through secure chat. And what are the expectations in terms of communicating test results, or other things. I do like to send everything to my student, and sometimes I don't expect them to do to communicate everything, but I give them the opportunity. Would you like to communicate these results to a patient, mostly for non-urgent results? Obviously, if something is urgent, I'm going to be doing most of the communication, but really involving the student in those communications can really foster that relationship with the patient, and that can really enhance the continuity aspect. And other things to do. I mean, I had a student who also didn't want to, many years ago, was very particular as to how I communicated with her. And it was really important to get that out of the way and try to understand where they were coming from, and for me to respect that communication style, but also for me to also assert that there were certain things that were needed in terms of keeping the patient safe and keeping the patient informed of what was going on with them. All right, and we have the advantage of having these students for about 6 months, sometimes a little bit longer, and that continuity with the preceptor and seeing that student over and over again really builds trust, because we're able to observe their skills, their development in terms of their skills, and that creates safe spaces so that we can provide feedback. And then give the students progressive responsibility. They should be, throughout the year, be progressing and getting, hopefully graduating from shadowing patients to doing, and then to doing more and more at each visit, including formulating assessment and plans. And I think in the LIC, it's such a easier process, because we have the opportunity to get to know them and to see them grow throughout the 6 months. So sometimes they actually get more responsibility by the end of that 6 months than a student in a traditional block model. So the goal for this year is for each student to follow about 3 panel patients per specialty. So across all and we want them to do this across all the specialties, and that really can be tailored to your clinic and also your students' learning goals. And hopefully this actually should create less work for you and not more work, because they can really be involved in doing some of that in between visit care, such as communicating test results or checking in after a subspecialty visit, for example. Next slide, Megan.
Sorry about that.
When did that happen? And also, the continuity is not just seeing a patient repeatedly in clinic. It can include, a patient you saw in clinic, then the student calls them with the results, and then they follow up with reviewing a subspecialist visit. It could also be a patient that's seen in clinic that's then admitted, and maybe they go see them when they're admitted, and then they follow up with a call to check in on how they're doing after the hospitalization. or, ideally they go to a delivery or they go to a procedure, and then afterwards call and follow up on the results.
Can I ask a question?
Yeah.
What does it look like in on the back end, I guess? So say I see a patient that I'm following with Elise and they do have results that come back before the next follow-up appointment, and I'm going to have Elise call to talk to them about them. I presume she's not going to know like how to interpret the results or what to actually counsel the patient about. And so do you have like a conversation over the phone or something to review what the plan would be for that? What does that look like for you?
Yeah, so I think so I like to give the student an opportunity to interpret that. And so as long as it's like not urgent, needs to be communicated right away. So I may send them the test result and say, do you have time to discuss this? Let me know, what do you think of this? What would you like to do about this test result? And then have a conversation so that they are conveying accurate information and able to have that conversation with the patient without me actually being there to supervise. So yes, we do have a discussion beforehand. Hi, Vincent. I'm so sorry that we started. Welcome.
No, I'm sorry, I'm late. Clinic ran late.
No
Totally
worries.
understand.
We're having a fairly informal conversation. We've been talking about the LIC and continuity as like the building principle, the defining principle of the LIC. Is this your first year working with our LIC students?
This is, yeah. So I've given lectures here and there in the past, but this is my first time having
Yeah.
a student.
One, and you are in neurology, correct?
I am indeed, yes.
Awesome. Can you just tell us quickly how things are going?
Oh, she's wonderful. No, she's great. I think, that is certainly my experience with LIC students who have come through like the wards, for example, I've worked with in the past. Like they seem to be self-selected to be very enthusiastic people for sure. And Erin, as you may know, has a family member who's a neurology, I believe a neurology resident at the moment. So she
Oh, wow.
she is maybe extra enthusiastic, which is wonderful. And no, I think she's picking it up. I think after each one, we sort of talk about the types of cases we saw, and we talk about sort of the physical exam maneuvers we did. And she's been, in essence, what I've been working with her is like she does the like she interviews people while I'm there. She does the physical exam while I'm there, and like her skills have really improved over the course of the block so far. So, she's doing a great job for sure.
Fantastic. Thank you so much for working with our LIC students. We've been talking a little bit about continuity. Has your student been able to see the same patient on multiple occasions, or been able to follow a patient across the health system in any way?
Ooh, that's a good question. I think there may have been one person who has been seen a couple times over the course of her rotation, but to be honest with you, I don't know if she has seen anyone through the health system in various environments. And yeah, I think she might have only seen one person a couple consecutively in my clinic.
Got it. So we were talking a little bit about the goal of having students follow about three panel patients per specialty. We know it's not always possible, but it is a goal that we work towards doing. That that can include multiple visits in the clinic, but it could also include seeing a patient, then like following up on a test results or communicating with that patient, what the results were. So as much as you can involve your student in doing those things, that really can enhance their relationship with the patients and can make things maybe a little easier for you as well.
Absolutely.
I wonder one thing that might work, and I don't know, this may not. I think sometimes I'll have the student call patients during the clinic time, and that can be another way that you're already there and they might be able to like ask you what to do after you ask them what to do about a result.
So like while they're with me, like to call the person they saw last time, is that what you mean?
Yeah, I didn't mean to interrupt.
No, I think we were going to say the same thing probably. So go ahead.
Um, it can just be really helpful for anyone that needs extra support, or how are you doing on this medication, or any side effects, or just checking to see if you have any questions, or if you were able to make the follow-up appointment, or Sybil, I'm sure you have many other examples from MedPeds.
Yeah, no, I mean, all those examples are, or those are great examples. And it also, I think, we don't always like teach necessarily, how do you communicate with a patient outside of the actual clinic visit, and there's a lot of care that occurs behind the scenes. That's not just in the clinic, and this is part of it. And it's not stuff that, students are necessarily taught. And the LIC is really a unique opportunity for students to engage in taking care of like everything, the whole aspect of patient.
No, that's a great idea. We haven't done that yet, at least in my experience. So that's a I think it's a great opportunity that I'll work in the coming sessions.
Fantastic, and let us know how that goes. Um,
Oh, for sure.
so, yeah, awesome. So I think just to summarize, continuity is the organizing principle of the LIC. It can be achieved by promoting office and staff supports, and also some creative scheduling. It helps build student and patient connections, and also fosters communication between students, preceptors, and our staff members. Um, I do like to try to set high expectations, and then we want to provide feedback as well as progressive responsibility as the student progresses. Mid-clerkship evaluations, which you're probably about to get fairly soon. Elizabeth can tell us a little bit more as to when those are going out, are great opportunities to go over formally what the student thinks they're doing well and how things are going, and what things they would like to work on. And then I do like to debrief after each clinic sessions on the things that went well, and areas for improvement, and things that they should work on for the next visit, or things that they should look up and bring back, and holding them accountable to that. And also another useful way of giving feedback is to, a lot of our students do document in the medical record, and if they're documenting, I do feel like I owe them feedback on that documentation. So reviewing notes is a great way to keep the students engaged as well. Hopefully, over time, continuity should create less work for you. And as mentioned, we are hoping for three or so patients per site with multiple encounters in the health system. And with that, I'm going to pass it on to Megan.
Thank you so much, Sybil. I will just quickly talk through clinical reasoning. Really, this is the foundation of the skill students are learning third year, and it's what makes it different from preclinical years. Like Sybil, I think it's really important to set high expectations and expect growth. And as we know, people get better through feedback, and that's really how the trajectory improves over the course of the year. We want our students to have a growth mindset. We certainly want to know if students are not receptive to feedback, and feedback really does help them develop expertise and be ready for practice. I know every specialty has a different way to think about what you're asking students to do, and this might be thinking about anatomy and neurology, or anatomy and OB-GYN, but really asking them to go from collecting and interpreting data to putting it in medical language, to recognize patterns, to be able to say, this is what the problem is, this is why I think that. I can compare and contrast it to other problems that it might be, and like to let students have time to do that work, to read and learn. Again, thinking about things we look for in documentation, they do submit H&Ps to be graded, wanting to make sure they're able to concisely represent a patient's presentation, and to use effective ways to communicate with colleagues in medical terms, really hoping that students get to this point and then are able to develop a plan of next steps for diagnosis and treatment. Encouraging students to look things up through your specialty, again, to be able to really think about what they saw and how this might be similar or different to things they've learned in other clinical settings. and to really encourage that, you may not have seen this, you may not know this yet, and there's plenty of podcasts and resources and YouTubes to have students look up and learn. I think one of the things that can be really great about having the students is the back and forth learning and communication, asking them maybe just one question for patients they saw, like, what else could this be? Or what might be one life-threatening, cannot miss thing? Or are there things that where this really just doesn't fit a common bread and butter clinical script for this? How do we think about multiple problems? What cognitive biases or other things could have happened? And then is this care happening at the right place? Like, have they managed to come into neurology or OB-GYN instead of ending up in triage or the emergency room? And if yes or no, why or why not? And really, I think these slides were made prior to the advent of AI really joining medicine, but wanting students to really hone their ability to ask a question that's relevant to the patient in front of them. So for dysfunctional uterine bleeding, is an IUD better than an OCP? Like asking them to take their learning and have it tailored to the patient in front of them. And to be able to do that in real time before or after clinic or in clinic. I'm curious what others have done. I think it can also be really helpful for students to look something up and bring it back, but to again be able to make sure that they're communicating what they find in patient-centered language, but having a reason for what they're doing and why. This is an assessment of reasoning tool, which can be helpful as you're thinking about just one thing on this, like what did a student do well? Going through things, are they taking a history where you're following and thinking like, yes, that's the next question I would ask as well? Is it confusing and all over the place? Is there differential, organized, prioritized? And then have they thought about things to do for next steps? And it can just be a way to foster feedback and set goals for next steps. Again, this is just a slide really thinking about this is truly what third year is. It's engaging with a patient as that patient engages in our health system. And so students are really well positioned to like help patients navigate the health system, to practice communicating a diagnosis in a way that patients understand, communicate treatment to patients, and then follow up and see how patients are doing over time. Any questions about that or how that's going? I know it can be hard early in the year, but I'll jump to grading and evaluations. Each specialty has multiple evaluations that really provide a longitudinal view of the student. The later evaluations are weighted more to reward growth, and then the evaluations do count towards their final grade. Evaluation comments make up the bulk of each clerkship summary, and your comments are in their MSPE, their dean's letter. Specific examples are really helpful, and interestingly, everything's written in the past tense. We'll have an example in a minute. Bias is truly widespread in assessments, and so thinking about the language and what is observed versus what you might be thinking. So really thinking about making sure that preconceptions or stereotypes, we've certainly, I think, seen one in years past of an LIC student that like the team commented on how she brought treats every time they were on call. And I don't think that that's what we want residents to necessarily see about our residencies to see about our students. So I think a template can be really helpful, like anything that we do in medicine, like what of these things was a student able to do? Where was their medical knowledge, their history and exam, their assessments and clinical decision-making? How do they communicate with you, with colleagues, with family or patients? How do they work with staff in clinic? And then this can be helpful to just pick 2 or 3 things to comment on, saying you worked with a student for a year, her clinical knowledge was excellent, comprehensive differential diagnoses, So really thinking about knowledge, communication, lifelong learning, but having things that demonstrate what the student did in the evaluation paragraph. And Elizabeth has looked at all of these and might have other ideas as well, so please chime in. And I'll turn it over to Sybil as well.
Oh, thanks. I was just going to add to the evaluations, anytime you can use a specific example that demonstrates those attributes, I think those can go a long way, especially for as I'm also an associate program director for the MedPeds residency, and we read tons and tons and tons of MSPs, and they all start to, sound the same. But the things that stick in my mind are those specific examples that people can provide, and also they really are great for the students when they go on their interviews. Then somebody can ask them about a specific situation or a specific patient encounter, and I think it can really highlight some of the things and the ways that the students have worked with the patients. And in particular, if you're having a lot of continuity experiences, there's usually at least one or two scenarios that pop into mind every year that I can write about my students that are like meaningful, and not only the patient benefited from that encounter, but I know that the student also benefited from that. And I've gotten feedback from students that they were asked about those things at interview. So just think about including some specific examples. All right, we're not going to spend a huge amount of time on this, and I know that you both foster a supportive learning environment, but wanted to talk about a few things. So obviously we want our students to have a good experience when they're working in our settings and working with patients and interacting in our environment. Give me just a second. Very important to learn and use our student names accurately, and to learn how to pronounce them so that they feel included. I know that in our clinic we've had issues. We huddle in the morning and in the afternoon before our clinic sessions, and the staff would say, "Oh, Dr. Sneas is here," and the medical student. And luckily, our residents are very attuned to this and clearly called that out immediately, and like, he has a name or she has a name, and they've really made the effort to use our students' names, and it really goes a long way to make them feel included and also part of as a valued member of the healthcare team. Acknowledge and interrupt microaggressions as they occur. So being prepared to gently name and address those in the moment, and debrief, appropriately and privately if needed, as soon as possible, if not right after the encounter, at least at the soonest opportunity to do so. We want to set norms for respect and belonging in our spaces. And model cultural humility and curiosity by demonstrating openness to different perspectives, and avoid making assumptions about identity or background. We want to be using inclusive language, avoiding gendered, ableist, or culturally insensitive terms when referring to patients, students, or team members, as sometimes we've heard about things happening outside the patient encounter, or the way that patients are referred to. We want to invite feedback on our learning climate. So maybe asking students periodically, how's the learning environment feeling for you? Anything that I can adjust, or anything that we should be adjusting? And then celebrate our students' contributions. They really are a valued part of the team, and oftentimes bring a lot to the table. So acknowledging student insights and progress, sometimes publicly, to reinforce that they are valued members of the team, that can go a really long way. And then, as much as I would love everybody to go into MedPeds, I really try very hard not to not to try to influence my students' career decisions. They are here to learn about all the medical specialties. Of course, I love it when they choose my career, but I'm really there to support them and make sure that they learn both pediatrics and medicine. And so we want to respect their choices and emphasize the value of different specialties and not talk negatively about other providers or other specialties. So those are just a few things to think about in our environments. These next 3 slides, I'm not going to go through, but they were shared. You've probably seen them already. They were shared by Dean Murtha. And so these are the attributes of positive champions of learning environment. And I'm pretty sure, Vinny, that you've already won 1 or 2 or 3 of these.
Thank you for yes, thank you for that. Yeah, but no, obviously great reminders. I try to do these all the time.
Yes, yes. And then the next slide has some tips about being an upstander and addressing microaggressions as they happen. So, sometimes we're so shocked when these happen that, we're just shocked into silence, but that can really leave a negative impression on our students. So if you can't address it immediately, debriefing afterwards is very important. And these are just some tips that Dr. Murtha provided. And then the next slide is on, oh yes, the medical specialty disrespect. So countering negative comments that we might hear about other specialties and just emphasizing the value of specialties. And we are particularly grateful that, we get to work with all of you in all these different specialties and that you're teaching our students. And so really value your time in doing this. And next slide. Thank you so much for teaching our students. We really value your work and your effort, and you're really contributing to the next generation of trainees. So we are really grateful for you. And I think now we could just open it up to general discussion. We're also happy to share our slides, so you have them, so you can have that wonderful schema that Megan shared regarding clinical reasoning. And then just some of the tips for continuity. So just would love to hear your thoughts about the LIC, about things that we should be doing, that we could do to improve, or things that we can do to support you in your work with students. And it's okay if you don't have anything.
I think I already asked, but I do have to hop off now and
Yeah.
go in. So thank you so much. And it was nice to meet all of you.
Same, Rachel.
Thank you
Thanks so
so
much for
much.
coming.
Yeah, thank you. Thank you for having us.
Of course. Thank you so much for your
Thank
work.
you so much.
All right.